Hello, everyone. Welcome back to PS Platypus. Today, we are going through gastrointestinal devices and investigations, including liver function tests. Forgive some dog noises in the background. All right, so to start off, just a brief disclaimer. I've definitely missed things. So this isn't a comprehensive list, but I'm doing my best. Okay, so in terms of devices, there are a bunch of devices that are used for investigations, for example, endoscopes. But really what I'm going to focus on in devices are those that aren't used for investigations, because I'll be talking about investigations. So things like nasoenteric tubes, so nasogastric tube, nasojejunal tube, etc., as well as a colostomy bag. And then in terms of investigations, we're going to talk through some bedside investigations, bloods, imaging, and other. I think that's generally a really good framework for organizing your thoughts when you're talking about investigations that you're going to order. Bedside, what can you do at the patient's bedside? Bloods, imaging, and then other tests. All right, so with devices, most investigations are performed with devices. So this slide is for those that aren't for investigations. So more for treatment. Okay, so nasoenteric tubes, such as the nasogastric tube, think about how it's named, right? Naso means nose, gastric means stomach. Nasojejunal, nose to the jejunum. So you're inserting a tube via the nose to access these different parts of your upper GI tract. And you can use them for various things. I think they're mainly used to deliver food and medications or drugs, or contrast for imaging. So you can deliver things like, I think, barium, and then do a CT with contrast. And so it'll light up inside the gastrointestinal lumen. But you can also use NGTs for removing contents in the upper GI tract. So for instance, if you've got a bowel obstruction, then the food that's gone in since and that is in front of the obstruction in your gastrointestinal tract will build up, and that'll increase pressure. And eventually you might have a rupture of your gastrointestinal tract. So in order to relieve pressure and prevent or reduce the risk of that rupture, you can insert an NGT, and that way you can sort of suck out the contents as the pressure is increasing. Once again, please forgive the noises in the background. All right, and then we have ostomy bags. So for instance, so you use them after a colostomy, which is when you surgically remove a part or the entire colon, for instance, because there's cancer there or some other damage. And so you've removed that. And so that means that you don't have the tube going all the way to the rectum and anus to actually normally defecate. So you need to collect the fecal contents another way. And so basically what you do is you create a surgical opening called a stoma, an artificial stoma, that is communicating between your gastrointestinal tract and the outside world. And you have that attachment, as you can see in the middle, the bottom image there. And then you can attach bags to it, and that collects the fecal contents. All right, moving on to investigations. So at the bedside, what can we do? Well, we can do urine analysis, we can do ECG, probably a couple other things we can do. But these are the two that I've chosen to look at. Urinalysis, you can do it via dipstick, which is just where you dip the little paper stick into some urine, or you can send it off to the lab. But obviously, when we're talking about at the bedside, we're talking about a dipstick urine test. Now, dark urine is usually due to increased bilirubin. So bilirubin is converted into urobilinogen, and that's actually what gives urine its normal yellow color. But when you have increased bilirubin, you have increased urobilinogen, and that darkens the urine. Now, if you have jaundice, then you can look at the color of the urine and the color of the stools to help differentiate jaundice. And I have a table down a couple slides that will look at that a little bit more. But the general idea is if you have dark urine, but normal stools, then it means that the urine is getting converted into conjugated, the bilirubin is getting converted into conjugated bilirubin and then urobilinogen. And so it's being excreted, but there's something going wrong inside the liver because the bile is still managing to get to the intestines to break down fat, and so and you're still able to excrete stercobilin, which is what gives color to the stools. Anyway, I'm rambling a little bit, but you'll see in a couple slides a table that sort of summarizes where the cause of jaundice is. If you have high sugar in the urine, then that is quite possibly due to diabetes, where you aren't taking in enough sugar into your cells. And so in type 1 diabetes, that's because there's been destruction of the beta cells of the pancreas that create insulin. And the pancreas is a GIT organ, as well as an endocrine organ. And you can also use urinalysis to help investigate. If someone has pain in the abdominal region, you might be thinking potentially a bladder infection or a urinary tract infection or a kidney infection as well. And those might be more suggested or discouraged in your differential diagnosis based on what you find in the urinalysis. And also if you have epigastric pain, so that upper region of your abdomen, then there may be, then a heart attack could actually be causing that pain, and or some other cardiac cause, because the heart is relatively close to the abdomen. So you can use an ECG to eliminate or reduce the likelihood that you're thinking of that and you're thinking more of a gastrointestinal problem. All right, a bit more onto the business end. Here we are with bloods. So you can do a full blood exam, and decreased hemoglobin is what anemia is. Hemoglobin being the oxygen carrying protein in your red blood cells. So if you have a reduction, that might be for a few reasons, but relating to GIT, what we'd be looking at is, okay, maybe there's bleeding inside the gastrointestinal tract, or bleeding into your intestines. And so because of that, you're having blood loss, and so you're losing blood, so you're losing hemoglobin. It could also be that you're not absorbing the nutrients that you need to produce red blood cells. So for instance, iron, B12, and folate. And so those are causes of anemia due to malabsorption. You can also look at the white cell count, and that might be increased in things like infection or inflammation of the gastrointestinal tract. Of course, there's lots more here in blood investigations, but I'm just sort of focusing on some of the main things I might think about with relation to gastrointestinal pathologies. All right, then you have urea, electrolytes, and creatinine, sort of looking at the kidneys. And you may be thinking about the kidneys because they're also in the abdomen, near the intestines, sort of. And you may also be thinking about electrolyte imbalances, especially in cases of diarrhea and vomiting, where you're losing a lot of fluid and electrolytes. C-reactive protein and erythrocyte sedimentation rates are measures of inflammation. So you might be thinking about inflammation in terms of infection or other forms of inflammation, or post-surgery, CRP will be raised, all relating to this sort of gastrointestinal aspect. And then we've got liver function tests, which is what we're going to focus on in this presentation. All right, they are likely the most relevant to of GIT blood investigations. All right, don't freak out. We'll work through this. So liver function tests measure the liver enzymes, ALT, ALP, GGT, and AST. And they measure liver products, so things made by the liver. Right? So stuff like bilirubin, albumin, and we can also look at prothrombin time for the clotting factors. Now, we request liver function tests in medicine for two main reasons, and that's to confirm what we suspect is liver injury or disease, and also to look at different causes of jaundice and determine whether it's inside the liver, so has there been damage to the liver, or has there potentially been obstruction after the liver, potentially in the biliary tree, for example, in gallstones, that is blocking the ability for us to actually excrete bilirubin in the urine and feces. So it's actually increasing in the blood, causing our skin and our eyes to turn yellow. Not ours, the patient's, sorry. We might be the patient. All right. Now, really, when we're looking at these liver enzymes, which is this slide, we're looking at these 4 enzymes: ALT, ALP, GGT, and AST. And I have a mnemonic. It's a bit dodgy because it doesn't actually relate super specifically to the enzymes. But my mnemonic is, I think about the pancreas and gallbladder, which are related to the biliary tree, right? They're connected to the biliary tree. And what do pancreas and gallbladder start with? They start with P and G. And so ALP and GGT are the more cholestatic enzymes. And we'll get to that word in a second. So AST and ALT are the aminotransferases, which are more related specifically to the liver cells themselves. Okay, so ALP, GGT, cholestasis, pancreas, gallbladder. We're thinking sort of about gallstones, for instance. All right, let's get on with it. So transaminitis is when your aminotransferases are increased. So that's your ALT and your AST. Now these enzymes, alanine transferase, I think, alanine aminotransferase and aspartate aminotransferase. I may have misnamed them. Those are associated with hepatocellular damage, so actual damage to the liver cells. Now, ALT is more specific. So we generally look at that more than the AST, but then we can compare AST and ALT to look at the likely cause. And you can read the slide here, but basically if AST is more than 2.5 times greater than ALT, then we're looking more at alcoholic hepatitis. If they're roughly equal, then we're looking at ischemic damage of the liver cells. And if it's less than 1, so there's more ALT than there is AST, then we're looking at things like chronic liver disease. So for instance, damage to the liver due to toxins or viruses. Okay, or I think non-alcoholic fatty liver disease. So that's transaminitis. AST and ALT, they're raised in damage to the actual liver cells. Cholestasis, choli meaning relating to bile, and stasis meaning static or not moving. So it's the bile not moving, right? It not being able to get out from the liver, out from the gallbladder, down the biliary tree into the duodenum, via the ampulla of Vata. Okay, so there's some sort of blockage, potentially a gallstone, that is preventing the movement out, right? And that's P and G, remember? Pancreas and gallbladder. But those enzymes don't relate specifically to the pancreas and gallbladder. That's not what those letters come from. It's actually, I think, alkaline phosphatase for P and something glutamyl transferase for GGT. I just remember the abbreviations. My apologies. Okay, so ALP is in the liver and the bile duct, and it's also in bone. So if you have an isolated elevation of just ALP, then you'd be thinking potentially of bone pathology, right? If the other liver enzymes aren't changed or aren't particularly abnormal. You might be thinking about things like bone cancer or some sort of bone injury or bone disease. Okay. And it's increased in, but if other liver enzymes, if GGT is also raised, then we'd be thinking, okay, this is a pretty cholestatic picture. There's some sort of obstruction in the biliary tree that is preventing bile from getting out into our duodenum, into our gastrointestinal tract. So we're not able to excrete it normally, right? GGT is also increased in other, due to other causes, such as alcohol and some drugs, I think, including phenytoin. But it's raised in biliary epithelial damage, so that damage to the bile ducts that come from, the liver and the pancreas and connect to the gallbladder and the duodenum. All right. Now, just to sort of differentiate between hepatocellular injury and cholestasis, we look at just the ALT, remember, from the transaminitis, and the ALP. So the ALT is the more specific one for hepatocellular damage, and ALP we look at as well. All right. So if they're, but often, you might get both of them raised. So you have to look at certain thresholds. So if ALT, if there's a more than 10 times increase from baseline of the ALT and a less than 3 times increase of ALP from baseline, then that's highly suggestive of hepatocellular injury. But if the ALT is less than 10 times increased from its baseline, and the ALP is more than 3 times increased from its baseline, then we're looking at cholestatic. So for ALP, it's whether or not it's more than 3 times increased from baseline, so 3, versus ALT, it's 10. I don't have a great mnemonic for that, my apologies. And you can also have a mixed picture. So these can both sort of be raised substantially, or it might be a bit more vague. They might not actually meet these specific metrics, but that's sort of how we differentiate between hepatocellular and cholestatic. 10 for ALT and 3 times for ALP, and then it's which one is above that threshold. So ALT, that transaminitis for the hepatocellular damage, and ALP for P for pancreas. Oh goodness, it's not actually related to the pancreas, but that's how we remember that it's not hepatocellular, right? It's biliary obstruction, cholestasis. All right. Now moving on to the liver products. So we spoke about the liver enzymes. The products are a little bit more manageable. And here's also that table that I was talking about, looking at the pee and the poo, the urine and the stools, to look at what the cause of jaundice is. All right. I'll actually talk through the cause of jaundice, this table in the bottom right corner first. No, I won't. I'll talk through bilirubin and then I will. There we go. Okay, so bilirubin is a breakdown product of hemoglobin. And you get unconjugated bilirubin from that. And then that unconjugated bilirubin, which is fat soluble, water insoluble, it's conjugated in the liver into conjugated bilirubin. Now, conjugated bilirubin is water soluble. Okay. Now, if you have a high bilirubin presence in blood, hyperbilirubinemia, that may not actually always cause visible jaundice. I've heard that it's about, I think, greater than 60 micromolarity can cause visible jaundice usually. But yes, you may not actually always get skin yellowing, but the patient may be on their LFTs have increased bilirubin present in blood outside of normal ranges. Now, unconjugated bilirubin is not water soluble. Remember, it's fat soluble. And this is before it's conjugated in the liver. Conjugated bilirubin is water soluble, and so it passes into the urine because it's water soluble as urobilinogen. So it's been broken down further. And that's actually what gives urine its color. If you have increased conjugated bilirubin, then you're going to have increased urobilinogen. So you're going to have darker urine. All right. And the causes of increased unconjugated or conjugated bilirubin, well, we can see for unconjugated, it's things like blood destruction, so hemolysis or damaged red blood cells, decreased hepatic intake. So the liver isn't taking in sorry, let me just elaborate a little bit more. Increased unconjugated bilirubin presence in blood, right? So it's unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia, right? So we're just looking at which type of bilirubin is increased. So if it's unconjugated, right, then the liver hasn't been able to process it at all, right? So that might be in just destruction of more red blood cells, hemolysis, decreased hepatic intake, so the liver isn't taking in as much, and so isn't taking in as much unconjugated bilirubin, and so that's building up in the blood, or it actually just isn't conjugating bilirubin. So that might be due to, for instance, maybe an enzyme deficiency. I don't know what enzyme, but just a specific enzyme wouldn't be doing its job. Great. Versus conjugated hyperbilirubinemia, conjugated increased presence of conjugated bilirubin in the blood. That might be due to liver injury or cholestasis. So most of what we were looking at on the previous slide. Okay. So the liver's been able to conjugate that bilirubin, but then it's maybe there's more bilirubin, right? And that's being released into the blood as opposed to being excreted via the feces and urine as normal in forms of stercobilin and urobilinogen, respectively. Goodness. Okay, so if we're looking at the cause of jaundice, right? Remembering as well that bile and pancreatic lipases are what help us break down fat in our digestive tract, right? So if we've eaten fatty foods and we aren't able to get bile and lipase, then we're not going to be able to break down that fat. And so the fat is just going to be passed on into our stools. So we're going to be excreting fatty stools. Okay, so if our urine and our stools are normal, then we're not conjugating that bilirubin, right? It's so there's I'm very sorry. It means that we're increasing the bilirubin and the cause is prehepatic, right? So it's not in the liver and it's not after the liver that is causing this jaundice, where we're increasing the amount of bilirubin that we're producing and that's building up in the blood. Okay. For abnormal levels. So think stuff like that hemolysis that we were talking about, right? You have lots more red blood cells that you're breaking down. That is lots more broken down hemoglobin into bilirubin, and that builds up in the blood. So we get jaundice, but we're not increasing the amount that we're excreting in the urine and stools, right? So the urine looks normally colored. The stools look normally colored. Prehepatic jaundice. Intrahepatic or inside the liver cause of jaundice will present with dark urine but normal stools. And that's because that bile and lipase can still get to our stools, so it can still break down our stools. However, we are still conjugating that bilirubin in the liver, and we're getting more conjugated bilirubin in the liver. And so we are converting that into urobilinogen because it's water soluble. And then we are excreting that in the urine. And so our urine's darker. Same thing with posthepatic. Well, actually, not. We are excreting the, yes, we're doing the same thing in urine, sorry. But the stools, because we have obstructive jaundice, right? We're not able to get bile out, like further out of the liver because we have a blockage in the biliary tree that causes a backup that causes jaundice, right? We aren't actually able to excrete the stercobilin form of bilirubin in the stools or into our gastrointestinal tract. So our stools look pale. They're also fatty because we have a buildup of fat in our gastrointestinal tract that we're just excreting instead of breaking down because we don't have that bile getting to the fat in our gastrointestinal tract. And the urine is still dark because that the conjugated bilirubin is traveling through our blood and is getting to our kidneys and is being converted into urobilinogen and is then being excreted. So that's why it's dark. Goodness, apologies for the jaunty explanation of jaundice. All right, albumin, that was the most painful part. The rest of it is totally manageable. You've gotten through it, good job. Okay, albumin is another product of the liver. It's made by the liver, and it's a transport protein, so it transports a bunch of water-insoluble stuff in the blood, for instance, fatty acids. And it also holds water in the blood, so it keeps fluid in our blood vessels via oncotic pressure, right? Osmosis and all that good stuff. Okay, when albumin is decreased, that might be due to things like liver disease, inflammation, causing acute reduction in albumin production by the liver, or loss. So you might be losing lots of protein in the gastrointestinal tract, or you might have nephrotic syndrome where your kidneys aren't actually filtering your blood well, and so your protein is being lost through your kidneys and you're peeing out protein. All right, so there's a few causes of decreased albumin, but it's produced by the liver. And then prothrombin time. So clotting factors are made by the liver. Prothrombin time measures the extrinsic part of the clotting coagulation cascade. And when you don't have things like a vitamin K deficiency or anticoagulants causing an increased prothrombin time, so a longer time it takes for your blood to clot, then it would indicate a liver pathology because your liver does make those clotting factors. So it could be actual dysfunction of the liver itself that is causing the increased prothrombin time. All right, we've gone through most of it. Thanks for sticking there with me. Now we're on to investigations imaging. So you've got a bunch of things, right? We've got ultrasounds, X-rays, CT scans, and MRIs. I'm not going to expand on them too much. Basically, they get, I guess, increasingly expensive there. There are different considerations of radiation, whether it's contraindicated for instance, pregnant people, how quickly you can do it, and the cost. So really you're thinking about what will it show me? How expensive is it? Can I actually do it in this patient? How long will it take? If I request an MRI, it's going to take longer than if I request an X-ray. Not that I'm requesting any imaging at this point on the third year. Okay. But really, when we're talking about GIT imaging, a lot of the time we're thinking about endoscopy. So you can have upper GI endoscopy, which is looking at the upper GI tract by inserting a tube down the mouth, down the esophagus, and into the gastrointestinal tract. And we also have lower GI endoscopy. So that would be things like your colonoscopy, where you're going via the anus and having a look to see if there's any observable abnormalities. You can also take samples with endoscopes and do a bunch of other things. You can cauterize. But yeah, basically they're a little camera on the end, and we can look in the bowels or the gastrointestinal tract as a whole. Okay. One specific example of this is ERCP, endoscopic retrograde cholangiopancreatography. So endoscopic, it's an endoscope. It's a scope inside, you're looking inside. Retrograde, you're going backwards into the bile duct, right? So you're entering the duodenum. So you've gone down into the mouth, down the esophagus, into the stomach, past the stomach, into the duodenum. And then you've gone into the ampulla of Vata to actually look in the bile duct, right? And you can basically use it to look, diagnose, and also treat. So there's different tools you can have on the end of your endoscope. And so you can sort of break gallstones and things like that. Okay, cholangiopancreatography. So cholangio, chole meaning bile, angio meaning duct, so bile duct. Pancreato, pancreas, and graphy, meaning like imaging or visualization. Sure. So that's what ERCP is. And it basically combines the upper GI endoscopy and X-ray, and you can be looking in the biliary tree, diagnosing and treating problems. A brief step backwards, looking at MRI, we also have MRCP. So this top right image here you can see in black and white. That's basically an MRI, but we've tuned the density, the radio density. So we're looking at that of bile. And so we can actually visualize with pretty nice quality the biliary tree and see if there's any obstructions, anything like that. This really is just a very brief summary, also because I don't know a great amount about it, but yeah, there you are. And the final slide. Once again, thanks for holding on. We're looking at just the urea breath test, stool culture, and fecal occult blood test. So if we're considering H. pylori potentially as a cause of gastritis or peptic ulcer disease, then we might do a urea breath test. So we give a patient urea to ingest, and that urea is isotopically labeled. So it might be carbon 14 or carbon 13. And then the H. pylori, if it's present, it produces a lot of this urease enzyme, which breaks down urea into ammonia and carbon dioxide. And so it breaks down it into ammonia and carbon dioxide, and then the carbon dioxide is excreted in the lungs. So you breathe it out, right? And so you can measure their breath, the patient's breath, and if it has a lot of that carbon 13, 14 labeled CO2, then you can go, oh, so there definitely is the urease enzyme in there that is breaking down the urea that we've given that was labeled. And so, yes, they probably have an H. pylori infection causing this. All right. Stool culture, it is what it sounds like. You take a sample of feces and you send it off to the lab, and they test for abnormal organisms. And so they can do gross examination. So they just look at it and go, oh, is there obvious blood in it? Things like that. They can do microscopy and look for other things. And they can do culture, and they do that via selective agar plates. And that's because, you know, you have an absolute bunch of bacteria in your gut, but you want to look for a specific thing. Okay. So you have plates that help a specific bacteria thrive. They have the right nutrition for them. And so you can go, oh, yes, it's grown a lot for this specific bacteria. So we're pretty confident that that's what's causing the patient's diarrhea and vomiting, for instance. Okay. And you can also examine parasitic infection, I think, via stool culture. Okay, and then the very final thing, fecal occult blood test. Occult means like hidden or not clinically obvious. So a fecal occult blood test, you basically take a stool sample and you use it to screen for small amounts, very small microscopic amounts of blood in the stools that aren't obvious, right? So if you have very obviously bloody stools or very dark stools, then you'd be considering bleeding in the gastrointestinal tract. But if you aren't sure, it's more of a screening thing. So you screen for colorectal cancer routinely. And there are a few different ways that you can do that, as shown in the bottom right image. All right, thank you for hanging in with me. If you have any questions, feel free to contact me. It's Kyle from PS Platypus, and I hope you have an absolutely wonderful day. Bye.